Please take over, sir, for the last presentation introduction and further, sir.
Okay, so thanks a lot, Tariq and Vivek. Unfortunately, because of traffic situation, I could not be there at present, but I'm online. And thank you that both of you did really a good job here. Because we are doing concomitant with another meeting in Delhi, so it had to be a little hurried. At the same time, I'm sure that when that meeting starts, we will have some good discussion about both your presentations. And if you're around, if you're not in the Delhi meeting, then of course it would be great. The third one is by Manish. Now, Nishant, are we having a recording or he's doing it himself?
So recording will go on, audio will go on, and simultaneously somebody will present.
Sure. So this was on the last day. Like a lot of excellent presentations were left behind because of the problems of time management in the last meeting. And this was one of the most salient, stellar presentation, which was not just an eye-opener, but all of us can learn from this. And it's a large experience. It's a novel experience. And Manish is going to talk about, we are dealing with stroke, all of us, but these are the patients who have already had sizable infarctions, and they are also way beyond the windows. And knowing him, he obviously is going to do the presentation. So it is going to be a mechanical thrombectomy in this subset of patients. And let us see what he has to say. We were extremely impressed, and I thought that because of the last day, not enough people were exposed to this. So this is another effort to do so for everyone who may have missed it. Manish.
Patient who is being referred by a neurologist, when they see a large infarct and a large vessel occlusion, the perception is that there's already a big infarct. So how does it help opening the artery? Just a technical thing. But still, despite that, we have had a significant support from neurology. So we have been able to do a few cases which to begin with had a big impact. I think something wrong. And also, none of the major trials that were conducted had included the stroke with large cores. The two studies which did include some of the patients were MR clean, but both these trials did not have a subgroup analysis of the patients with large infarcts. So this was in 2017. Again. So this was in 2017. I think Uday was there. We were sitting in a meeting, and I got a call that this 3-year-old girl we have now diagnosed as a stroke, which she had come about 12 hours earlier. And the diagnosis was missed. It's pretty difficult to diagnose stroke in small kids. So it was missed. And then when they did suspect stroke, again stuck. Okay, so next morning when the consultant saw, You can see the video that she is just not moving the left side at all. So he was completely hemiplegic. And this is when the diagnosis of stroke was made and the MRI was done. And when the MRI was done, this is, I think, about more than 18 hours and huge infarct to begin with. So I was very, very reluctant. First, it was a kid, and secondly, a huge infarct which is already there. And although there was an M1 occlusion here. But the neurologist insisted that we should give it a shot because sometimes the kids can have a better response. So with that thing, we decided to go ahead with the procedure. This was the DSA. I think we have shown this case before. There's nothing much technically in this. So we had used a Trevo at that time, and this was with 2 passes. This was the final angio. This is what was removed. So this is a big cheesy material that we removed, and later on she was found to have infective endocarditis. This was the MRI next day, which just shows the evolution of the infarct. But surprisingly, this is how she was after 48 hours. So this was quite a dramatic improvement despite this large infarct. So this is what encouraged us. And then we did see a couple of papers which said that, this is a paper which was published in 21, which is a meta-analysis of 12 studies. And in this, the large infarct was defined as the aspect which is 5 or less, or an infarct volume of 50 ml or more. About 491 patients were treated with thrombectomy, endovascular treatment, and medical management was given to 691 patients. And if you see the functional independence in the endovascular therapy arm was definitely significantly better. It was 25% versus 7% in the medical arm. Mortality was also reduced, although the symptomatic ICH was slightly more. So overall, even this study proved that it improves the functional outcome at 90 days as compared to medical management. This was another paper which came this year. This is from Japan, again a small study of about 200 patients. Each the endovascular therapy and the medical management, both were 101 or 102 patients. And again, if you see the functional independence, they had used MRS of 0 to 3. So this was, it showed that 31% of the patients who received endovascular therapy had a functional improvement versus 12% in the medical management arm. And the mortality was also reduced. So anyway, this is our data. So we analyzed our own data of last 4 years. This is from 2018 till now. So you found that we had about 70 patients which fit into the criteria of a large infarct. So these are those 70 patients that we have. So we have about 43 males, 27 females, and the median average NIH was about 15. We had about 91% recanalization of 2B or more. And these are the MRS scores. So if you see 0 to 2 was seen in about 31% patients. And if we include 3 also, then it becomes 49%. 0 to 3 is about 49%, which is a significant improvement in patients with large infarcts. Let's see some of the cases. Like this is a young man, NIH of 17. So he presented with left ventricular stroke, and he reached a nursing home within 30 minutes. And this is what his MRI was when he reached there. And if you see, the infarct is not very big at this point, but nothing was done. After 24 hours, he worsened even more. And that's when the relatives called me. So, and we shifted him here to our hospital. And this is what the MR looks like. Oh, it's pretty large left-sided dominant side infarct. And this is the MR angio. So again, we see that there's a big loop here in the cervical ICA, which looks like a dissection. And although MR angio doesn't look bad, But if you look at the DSA, his NIH was pretty high, and this is the DSA. Again, you can see that the loop and the dissection at the loop, the tonsillar loop, so-called. And if you see the angio, again, you see this is a superior and the inferior division. There is slow flow in both the divisions, but they are occluded distally. So you see here there is a gross hypoperfusion, which is hardly any flow going beyond this. So again, we made a couple of passes. And this is the neuron. First, we went in with a microcatheter because it was a dissection. And then the neuron was taken beyond the point of dissection and thrombectomy was performed. So this is what we had. So we had a T3 flow. Looks good. So this was a CT on 4th or 5th day post procedure. It just shows the evolution of those infarcts we had seen. He had significant clinical improvement after this. I'll show you the videos. But after a 1 month, we planned to do the stenting for this dissection, which is at the tonsillar loop. It looks pretty bad. So we use neuron and neuron max. Not really difficult to cross the loop. So first, this is the neuron which is going up, and then the neuron max. Our idea was to put a stent graft. So you'll see the neuron max also takes the bend. Yeah, here it takes. So we deployed the B graft. This is the first one. It did not cover the entire segment of the dissection. So we tried another graft, but it got stuck in within the neuron max. So second stent, we deployed a bare metal stent. This is the second one. And this is the angio after that. Looks really good. Not always the loop straightens, but you can still do it on the veins. So this was the angiogram, and these are the Dyna CT images of the stents. And this is the patient. And this is the message which was sent by the patient's wife. So he is a software professional. He has improved significantly. His speech is still not up to the mark, but if you can see the way he is, looks practically normal, except for the speech, everything else is completely normal. So this was more than 24 hours and a huge infarct and on the dominant side. So I just added, this is just off the topic. So we had here quite a few cases which we have done on the tonsillar loops, the dissections. Like this is another girl who had presented with a dissection in the cervical ICA. So again, stenting was done. And this was again, this is again not the topic, but since we saw this yesterday, this we had done about 7 or 8 years ago. So we have quite a bit of these cases, at least 3 of them I could find right now. This is just off the topic, but this was a final angio of that patient who had a bad aneurysm in the bed. So anyways, this is the second patient. Now this is again a young lady with a pretty high NIH on chemotherapy, and this is her MRI. Left MCA right face stroke, 15, NIH is 15, and a huge left-sided infarct again. And if you see here, this is when we have rapid, you see the infarct volume is already about 152, which means it's pretty large. It's obviously slightly exaggerated, but because the infarct is patchy, but the software calculates as the entire thing, so it does exaggerate it a little bit. But despite that, there is a significant mismatch. And the M1 was occluded. Procedure was straightforward. This I think we had done aspiration in this patient. After one pass, second. This is after the second pass. This is key 3 at the end. And this was the MRI next day. It's pretty large infarct, but she improved almost completely within 48 hours. So this was the MRI angiogram on the next day. And NIH was 0, which was 15. And with such a huge infarct on the dominant side, NIH from 15 had dropped down to 0. And this is the follow-up at 6 months. This is again another patient, NIH of 14. You can see the infarct, which is pretty large again. This is on the right side. So you see 200 ml. Here's the calculated volume of the infarct. And the mismatch ratio is 1.4. This was the angio, which shows the ICA occlusion. Artery was a bit tortuous. This is what it looks like on the DSA. This is selective shoot inside the ICA. It shows that there is very slow flow, which is reaching almost up to the supraclavicular segment. So it's a T occlusion. So this was the first attempt made with the centrifugal. This is after the first pass, didn't come out. Second pass, again slightly better, but nothing significantly better. Third pass, we had to do multiple passes. This is after third pass, nothing open. Then Sophia was taken. This is recent one, so the Sophia was available. It was just pushed without any coaxial system. After the first pass with Sophia, also there was a slight improvement, but nothing significant again. With another pass, and this time we could open. Looks good after 5 minutes. This is where we finished. So it looks sticky, good flow back into the ICA. This was the final angiogram, and this is a MRI next day. So if you see these MR, most of these infarcts are actually patchy. So there are islands of neurons which are actually preserved within the areas of diffusion defect, which is what usually is missed out and is responsible for the improvement of the patient clinically. So 90-day MRS of this patient was 2. He had not recovered completely, but at 90 days, the MRS was 2. This is another patient, 61-year-old, NIH 17. Again, left side big infarct. Left MCA occlusion. Cervical ICA was occluded here. Again, the routine steps, we have put the pneumomax in the cervical ICA, aspirated from there, and then the aspiration. And then the aspiration, the A68 was navigated into the MCA. This is after multiple passes we could achieve. One division still did not open after repeated attempts. This one, so we left it at this. This was the CT. The edema is quite a bit. This is the CT angio, which looks the same as the post-procedure DSA. These are the follow-up CTs. I think she needed decompression. Discharged after 2 months of stay in the hospital, but this is what he is at 1 year. He is walking with support, so MRS 3. Otherwise, he's completely normal. So again, another 46-year-old lady. Not all the patients do well. So this lady also had a NIH of about 12 hours from onset. And this is a MR, fairly large infarct. So again, infarct volume, if you see, is 175 ml here. Not a big mismatch ratio. So M1 is occluded. Again, bad loop with the cervical ICA. And distal M1 occlusion. Actually, it's not a complete occlusion. You can see that it's like a free floating defect in the MCA with little bit of flow which is going across. Here, you see here, there is some flow across this thrombus. I think we use a solitaire here to open the artery. This is also the second pass. This is after 5 passes. It was bad, so we made multiple attempts, multiple devices. And finally, it would open, re-occlude. And this is what we had finally, and this is what we left it at. It looked fairly okay, much better than what we started with. But we stopped at this point because the flow was looking better. And we had made enough attempts with multiple devices. So we stopped at this point. She was shifted to the ICU, worsened, taken back for an MRI after 4 hours. And this is what it shows. The infarct has progressed even more. And now if you see, the ICA has got occluded. Previously it was M1, and now it's a restroke with ICA occlusion. And this was the CT after the relatives refused any decompressive surgery. So this was a CT, and we lost her. So these are a few of the examples of the cases that we have done with the in patients with large infarcts. So if we compare the data, is practically very, very similar to the other two papers that we saw. Our numbers are not very big, it's about 70. But if you see what is most important is 0 to 2 MRS at 90 days is about 31% of the patients. And if we take 0 to 3, it comes up to around 49%, which is a significant improvement compared to the medical management. So these are the patients who have done really well with thrombectomy. So I would end by saying that there is definitely significant functional improvement even in the patients who present with a large core infarct to begin with. I would say that there is nothing to lose in these patients, so it's always worth giving it a shot.
Okay, thank you, Manish. Is there any window for you, like you don't believe in any window period?
Okay, sir. Can you hear me?
Yes, I'm here. So we have finished 3 presentations we wanted to. What I need to know is that Vivek and Tariq have left our meeting, or they are still around.
That is based on rapid. That is based on rapid. Otherwise, no. What I was trying to ask you is
still around. Dr. William is also around.
Okay.
Yeah, I am here.
Oh, fantastic. So then, taking a short time, I think we should cut this discussion which happened in the meeting and rather do it live now. And so, because Vivek and Tariq might leave us sooner than Manish, I would say that from the people in Delhi, if you have any interaction or question, is Manish around?
Yeah, I'm here.
Great. So people in the Delhi meeting, if you have any interaction or want to ask any comment or question to Manish, I think we should do that first.
Okay, I have a question. Okay.
Yeah, please go ahead.
Hello. Yeah, yeah. So this was actually a very interesting presentation by Manish. But what is the take-home message? Do we intervene everywhere and wherever we see a large core? Because the results are fantastic. MRS of 3 of almost 50% of the patients is like a fantastic result. But and the symptomatic ICH is also pretty low. But this is not what we usually see when we do once in a while when we do a large core thrombectomies.
That's the difference between doing once in a while and doing it regularly. So, in 4
Correct.
years,
Correct.
yeah. So, in 4 years, we have around 72 patients. So, in the time we made this presentation, it was 70, but now it should be around 75. And as you saw, the data is pretty encouraging. It's 49% MRS of 3 or less, 3 or more is pretty good, I would say. Functional outcome is pretty good. So I think we should give it a shot because anyway they don't have any other option, any other better option.
The real fear is about the hemorrhage, right? So that's what stops everybody.
But if you don't do anything, then the outcome is going to be bad anyways. So if you have a hemorrhagic conversion in about 8 to 10% of the patients, also it is acceptable.
So this point is actually very encouraging that out of 70 patients, you had a hemorrhagic conversion in less than 10% of the patient. So this kind of data we don't have. So if
that was the idea when Rudresh said, even we were not aware what are the exact numbers. So that is when they asked me, that's when we removed the data, and we were also pretty surprised to see the numbers. So
this is very encouraging. Thank you so much for sharing this. Thank you.
Hello, Manish. Hey, William Harris. I really thank you for presenting your data. I think that sometimes these are very challenging cases, not from a technical standpoint, from an outcome standpoint. We all know that you're not going to get the great outcomes that sometimes you do with these small core infarcts. I have two questions considerations for as you collect your data further. And my first question was, have you noticed any decrease in decompressive hemicraniectomy rates for these patients? And my second question was, in regards to last known well time, have you been able to stratify your results in terms of kind of fast progressors and slow progressors? My suspicion would be that you get even better results in the slow progressors rather than fast progressors. And thanks again for sharing your data. I think that was really interesting.
So the first question, about the decompressive craniotomies. Yes, if we have achieved 2B or 3, I think almost all the patients we have been able to avoid a decompressive craniotomy. There have been patients like the one we showed right now, where the recanalization was like grade 2. Those are the patients who would or who might end up needing a decompressive craniotomy. But if it is 2B or 3, then most of the time we are able to avoid a decompressive craniotomy, which in itself is a big deal. And second question was, of course, slow. The patients who have a slow progression of the stroke are definitely, so patients who to begin with are in, who present with a very high NIH in the beginning itself, in first 1 or 2 hours, they are the ones who are not likely to have a great clinical outcome.
Any other question?
Nishant, Manish is going to be there and we are going to be there. So we can discuss this after the Delhi chaps have left us. Okay, yes, so is there now, let's move, if from all of us or from William, if there is any question or comment to the first two presenters, Tariq and Vivek. So if none from there, then I have a couple of questions for Tariq. Is he around? He's online?
Yes.
Fantastic, Tariq. Thank you very much. See, my question is, so you showed beautiful images, and obviously it is meaningful imaging so that we can treat our patients. Now, in your place, and there are at least 30 people that I can see here who are practicing vessel wall imaging. Now, who calls the shots? Now, you do such beautiful imaging and you show that the patient who is symptomatic and the vessel wall imaging has shown something abnormal. Now, what's the conversion rate from imaging to the DSA? And of course, if you see something, the procedure. is the conversion near 100%, or the neurologist or whoever calls the shots is still skeptical?
Dr. Uday, so there's nothing 100%. Yeah, the vessel wall imaging, basically the patients, I would say I'm in that scenario where I'm fortunate enough that the 100% shots are taken by me on those things. So we started this vessel wall imaging not as a tool to convince others. We started this vessel wall to convince ourselves first, whether when we are going ahead with these ICATs, are we doing, because there was a lot of skepticism about that. So we started to do it to convince us that yes, we are doing right. So the conversion rate among those patients, we started with those patients where we were completely, the patients were referred for an ICAT. We started with those patients. So most of our data for a vessel wall imaging are those patients where we have converted the patient. So the patient it was for us referred to us for nicotplasty. So it was more of a correlation or rather a retrospective thing for us, so that we build a data, we build a confidence on it, and then we start to interpreting those things. So that was the start, and still it's an initiation, and we have not reached a conclusion.
Okay. So the other one is a corollary to the first question itself. Now, at least the significant number of patients that you would have done a DSA after a positive vessel wall. Now here I can ask you whether the number of a DSA abnormality, however subtle it might be, is this number at least close to 100%? That the patient who is symptomatic, who is positive on vessel wall, and you have done a regular angio to look for luminal abnormality, however subtle it might be. Is this matching?
So the specificity of our, when we started doing this thing again, still it's about the FOV, the amount of area we are able to see on the MRI. So we keep on decreasing the FOV to get a good high SNR to see that what we are seeing, is it true or not? Specifically when the artery is piercing dura, when the artery is around the cavernous sinus, these are the gray areas of a vessel wall imaging in the intracranial location, where what you are seeing is not, and probably in a patient, elderly patient with a lot of CSF is around. So the atrophic brains. So these were there where we say no, what we were seeing on the vessel wall. So it was a retrospective again. The vessel wall was showing a lot more areas of narrowing, which was not well seen on the DSA. As I've shown one of the case where the carotids, where the DSA was showing not that thing, and we got convinced by doing a Doppler, and then followed by that we demonstrated by a vessel wall imaging that yes, but we are dealing is a unstable plaque with an ulceration, and where we need to intervene.
Okay, I think that was very useful, because the eventual aim is that the patient is symptomatic. So either you go conservative way, which even today, a large number of neurologists would continue to conserve, especially if it's the so-called ICAT, if it's intracranial, then a large number of them are still going towards conservative. So, all these are actually ways and means to study further, so that can we help this patient further? Can we help this patient more? And because they deserve to be helped, because most of them have repeated TIAs, and sooner or later, half of them at least have a full-blown stroke. So I think you showed beautiful images, and this is, of course, work which is being done now almost 10 years now, am I right?
More than that, in fact, we've been doing for the last 12, 13 years. So vessel wall imaging, at least in our center, is now a regular feature in patients who have recurrent strokes without a significant luminal stenosis.
And we started to expand our patient base. In fact, I would admit, frankly, that we started to expand our patient thing. And
Okay.
then we found it interesting and useful, and then we pursued that thing.
Fair. Okay, thank you very much. And just one question to Vivek, if he's around.
I think he's traveling. Uday, he's on the way.
Oh, so is he? Can he take a question or not?
I'm not sure if he's able to.
Hear us? Okay, no
Yeah.
problem, no problem. So you know what we can do is that
He's just calling. He's just calling. Yeah, but hello. So Uday, I think he's reaching here. I think he just called from, maybe he's just driving into the hotel. So
oh, no problem. So I think we can do that later also with him.
okay, fine. So we will log off then.
Yeah, thank you very much for accommodating. I think it was very good, and the audience actually was a little wider than just the Mumbai INR and online people. So thanks a lot. You guys have a great meeting, and we will continue with ours. Thanks.
Thank you. Bye.
One more presentation. We are set for the last presentation, sir.
We are now set for the last presentation, after which we will go back. If anybody else wants to add, Karapur Prasad is also there. Some questions, comments to Manish, but I think the last is Rudresh. Actually, you were supposed to be the first, but because of the Delhi meeting, we have to turn it around. And thank you, Rudresh, for waiting patiently. Is he online?
Yes, sir. Thank you, sir. Thanks.
Okay. So you can start with your presentation. I know that actually in just 2 prizes that we gave for presentation, your name was not there, but yes, you're here because people have actually noticed it and have told me that in case you're doing this extra innings and things which were left and things which were good, which not enough people saw. So thank you so much for joining, and I think you can start now.
Thank you, sir. Good evening to all, and very warm good evening. And thanks for the outset. I would like to thank Uday sir and the team STNI organizing committee, and my guide Dr. Suresh Girigan sir for giving an opportunity to present here in this forum. So I'll start with my presentation. So today I will be presenting an unusual case of occipital diploic vein arteriovenous fistula with intracranial shunting presenting as a subcutaneous pulsatile mass. My patient is a 17-year-old boy presented with pain in the swelling in the occipital region for 1 week. On examination, the swelling was firm and pulsatile, and blood could be felt over on auscultation. No focal neurological deficits are present, and patient does not have any comorbidities. Routine lab investigations and the coagulation profile were the normal range. The MRI was done outside, which showed these are representative images, axial and sagittal T2 images, showing a large mixed intensity lesion with peripheral T2 hyperintensities and the occipital region on the right parasagittal location and having mass effect on the underlying right cerebral hemisphere. Top image shows a venous sac in the right occipital region, which is having multiple feeders from both ECA, as well as the both transverse sinuses are opacified. Flow enhancement is seen on top. These are the CT done on admission, CT angio and then CT, shows a large transosseous expansile lytic lesion with in outer phase early filling this venous sac, which is communicating to torquilla and having some areas of non-enhancement region in the peripheries may be representing thrombus. To summarize, pre-op imaging, there is a large extraaxial mass lesion in the right parasagittal location in the occipital region with having a communication to the torquilla. And on CT, you can see it is a transosseous occupying the intradiploic space as well as having a communication to torquilla. And you can see the multiple tortuous collaterals from ECA feeding the venous sac in the midline. In the venous sac. Subsequently, patient was subject DSA was done with selective images represented to DSA run. selective occipital artery runs, I will showing you, which shows multiple lateral meningeal branches from the both right and left occipital arteries, communicating with the venous sac in the right parasagittal location, which is a lobulated venous pouch. This is the 3D image of the right occipital artery injection. These are left occipital artery injections, showing similar multiple tortuous occipital meningeal bends from the occipital artery, communicating with the venous pouch in the right parasagittal location and into the torcular and bilateral transverse sinuses. This is the left anterior oblique view of the ascending right ascending post-auricular branch, and this is the 3D image of the left occipital artery as well as post-auricular artery occipital branches. These are even the vascular sac present in the right parasagittal location is having feeders from occipital branches from both the vertebral artery. These are the lateral images of both right and left injections, showing multiple tortuous arterial feeders to the venous sac. To summarize DAVF findings, these are the printed images showing diploic arteriovenous fistula with early filling of the occipital emissary venous sac, which is further draining torcular and bilateral transverse sinuses through a circular opening in the torcular from the venous sac. So this is the representative images, schematic images. In image A shows the occipital diploic A-shape communicating with the venous pouch, which is shown in orange color, into the torcular through a circular hole, which is depicted in the gray color. And the proposed transvenous approach for the treatment of the embolition of this venous sac been planned, and the white line shows the microcatheter cannulation through the transvenous approach through the torcular communication line, and occlusion of the circular hole by balloon catheter, which is depicted in green line. After multiple disciplinary discussions, even the surgical as well as transarterial approaches were discussed. Finally, the transvenous approach was opted for better treatment. Your representative DS runs have been done. This is the we took approach from the both right femoral and right venous. Right femoral we placed a multiple catheter for check angiograms, and here in this we took that neuron max into the right IJV and then into the transverse sinus, and here is the defect which is having competitive flow from the injection. So after that we passed the first microwire into the venous sac to the torcular communicating opening, and further the second catheter also passed and placed into the venous sac. Subsequently, later on, few detachable coils have been placed, target axle from striker and the axiom prime coils were deployed across the communication point. Later on, we inflated the balloon, the eclipse balloon, across the communication point to prevent the reflex, and we plan to put the now across the after placing the coils. Subsequently, we placed inflated the balloon and then started injecting the liquid ambuloglifs, squid and Onyx. Onyx 34 we used about 4.5 ml, and squid about 6 ml, and 10.5 ml Onyx 18 sequentially. This is the final check angiogram, which shows complete obliteration of the lobulated venous sac in the occipital region. To summarize the ablation process, here we show that in the first image we show that there is a communication, that filling defect, and then followed by the first catheter pass into the sac, then followed by second catheter, and then coil embolization, followed by balloon this inflation, thereafter the balloon occlusion, thereafter putting this cast liquid embolization material, and followed by a check engine which was complete occlusion of the venous sac. And these two are the fluoroscopic images where you can see the Onyx cast. Image after the procedure was uneventful and the patient was extubated immediately, and there is no new neurological deficits or any other uneventful this thing. And post-embolization day 1 axial MR image shows, this is figure A, is the Onyx cast in situ, and no evidence of CBT was there in the MRI, and no evidence of any further intracranial or extracranial hemorrhages. And the second image B is a 1-year follow-up MRI flare image showing shrinkage of the venous sac with the decreased mass effect on the right cerebral hemisphere. And in the top MRI shows there is no evidence of filling up the venous sac or any evidence of venous filling. This was a patient post before discharge in the embolization. The hardware used by 6-branch Neuron Max, 5-branch Navian guiding catheter, 4-branch glide catheter, Prograde micro catheter, Echelon 10 micro catheter, 6x9 mm dual lumen eclipse balloon catheter, target XL standard coil, Axiom Prime 3D coils, Onyx 34 skid tool, and Onyx 18. Synchrosoft Whisper extra support micro guide wire of own 4 size. A short discussion regarding the dural AV fistula. A classical dural AV fistula accounts for about 10 to 15% and located predominantly on the dura adjacent to the venous sinuses, skull base, and orbit. And other forms of AV fistula having meningeal artery feeders are the intraosseous locations, either in skull base or in calvarium. The skull base intraosseous AV fistulas, the point of communication will be between the meningeal arteries and the intraosseous diploic veins, or transosseous emissary veins involving the hypoglossal canal and anterior or posterior condylar veins. AVFs involving the calvary diplex are rarely described, however, but among, if at all found among them, the parietal bone is described to be the most common one, as the higher density of diplex channels were found in parietal bones, followed by frontal and occipital bones. Clinically, they can present as a scalp hematoma, epidural hematoma, or with symptoms of cortical venous reflex akin to that of the classical dural AV fistula. The venous varix secondary to the fistula present as a pulsatile mass is rarely described. Anatomically, the diploic space AVFs are located either on the diploic venous channel or in the emissary veins. Here we presented a rare case of occipital intradiploic space AV fistula presenting as an occipital mass and treated by transvenous embolization. In our index case, the venous varix itself may be represented in emissary vein, which is connected to the torcula via a small oval-shaped pinhole transdural communication. Pre-procedural CTA and DSA with 3D rotational angiography are helpful in evaluating the site of the fistula and management, including planning of the optimal route of embolization. Coming to the etiopathogenesis, in classical dural AV fistula, it is well established and known that most commonly it will be secondary for the chronic cerebral venous sinus thrombosis, and they do not involve diploic veins. However, in diploic AV fistulae, the etiopathogenesis is not well established. However, some cases the trauma is to be the causes. In our index case, the lesion is more appears to be a developmental onset, as the presentation is in second decade, as well as the lesion morphology is expansile scalloping and scalloping of the surrounding structures, which suggest a slow growth of the lesion. Here in diploic AV fistula can have 3 types of venous outflow: draining directly to dural sinuses only or towards the extracranial veins, or combination on both ways, as they are valves. The treatment both surgical and endovascular techniques are available, but among the endovascular techniques, various including transarterial, transvenous, direct intraosseous embolization techniques can also be employed. In index case, the surgical treatment deemed technically difficult, as well as for transarterial, because the fistula was having numerous transosseous as well as meningeal arterial feeders and communication of varix to the corpuscula. To conclude, a calvaryal intradiploic AVC can present as an expansile pulsatile subcutaneous mass, and recognition of this entity and to understand the angioarchitecture of the fistula is essential for the planning and the management. These were the references which I took for the basis. And this is the end of my talk, and thank you for patient hearing.
Thank you, Rudresh. That was really, really wonderful. And thank you, because many of us did not actually go towards the e-poster area, and we may have missed an excellent case, rare and very well done. Any question over there for Rudresh?
Rudresh, this is
Yes, sir.
Nishant. Yeah. So, have you given a thought, as you were, the last slide you said this entity, you must have read something more about this, right?
Yeah.
Did you consider ever that it may be a dual variation of dual sinus malformation?
So that also came to mind, sir. But the venous pouches are like lobulated, and both it is having a communication with directly communicating with the torcula with a clear-cut opening. So it could be that same diploic or the emissary veins could have been like what varix.
Correct. So if you remember now, one of the very benign form of dual sinus malformation is the occipital imagery shunt, which is the most innocuous form of dual sinus malformation.
Okay, sir.
Yeah. Otherwise, the management remains same. Just because you have put so many references, just have a look.
Okay, sir. Yeah.
These are not run-of-the-mill cases. You may not get ever in your practice. Yeah.
Yes. Thank
Sir, back to you.
Okay. So, yeah, we have to think about this. But, classically speaking, his dual sinuses were of normal caliber. They were not large, enormous, or malformed. It was just like the patient also came with a pulsatile swelling in subcutaneous beneath the occipital protuberance. And the very fact that you mentioned about the occipital emissary, which goes through the squamous part of the occipital bone, which is extremely normal in most of the human skulls. This was actually something which was in the destroyed part of the skull, which was in the diploe, and then extending into the subcutaneous. So that being said, the most important part of this treatment was to save the torcular, because once you decide to use the liquid, and the liquid will communicate sooner or later with the torcular, which is completely normal. So to save the torcular from the malformation or the fistula, I think was the most important part of the treatment that you did. As you rightly said, it could be transarterial, transvenous, as you did, or even percutaneous, but you had to save the torcular from your liquid embolic
reflux
to seep through. Yeah, beautiful. And you chose to do it with a small balloon, with which you actually occupied that emissary, the occipital emissary, which was quite cute, I thought. Well done. Lovely case.
Thank you, sir.
Okay.
Yeah, there are no questions. We can conclude then, sir.
Yeah, can we go back? Is Dr. Kalapur want to say something about Manish presentation? Because that's I cannot still overcome. Is he there, or he's logged out?
I think he's logged out.
Okay, no problem. Fine. So, the last question is, you keep talking about, even on that Sunday in Goa and now, about patchy infarcts. So do you think that patchy infarcts, when there's large vessel occlusion? So I didn't see, or maybe I missed, the actual collaterals which existed. So some of those collaterals could be responsible for the patchiness of the infarction. I mean, because I did not see very many collateral images from other circulations, or maybe I missed it. So can you talk about that?
Yeah, so actually, if you see, even if we go back to the presentation, which right now is difficult, but there are most of the patients who have decent amount of collaterals. So those are responsible for those patchy areas which are still preserved and can be saved. So finally, it boils down to collaterals. Now I think dictum has changed from time is brain to collaterals is brain. So. Hello. Uday.
Yeah.
Yeah. So
And one more question. In the cohort where you failed to recanalize, those were fast progressor or slow progressors?
we have not been able to recognize about 3 or 4 out of all these patients. I think all of them were pretty
Large.
large.
So fast progressor. And
NIH our presentation was pretty high.
and the clot analysis, what you got?
No. So we sent a few clots, but we never got any
No.
definitive.
Visual impression.
I
White.
No, I don't. We see, first of all, we hardly get any clots which we can actually see. But most of them have been red, but I don't feel that that's going to make any significant difference as far as recanalization is concerned or anything else. So we actually don't believe in that clot composition or clot morphology prognosticating anything.
And in all this 4 failed one, all did badly.
Yeah, all did that. We showed 2 other patients here. Yeah. So others also didn't do well.
And not a single one ICAD angioplasty.
None of these
Not
in the series. I don't remember doing acute stenting at all. In fact, we did one in last month. But that way we lost that patient. It was stent got up to them.
So in retrospect, we can say that all these large volume infarct without ICAD suggests that in ICAD we get very good collateral. That's how they sustain over the period of time, isn't it?
That's right.
And they don't infarct like crazy.
Yes. So collaterals are definitely much better. So those are the patients you are likely to have smaller infarcts.
It's smaller infarct and huge phenomenon.
Yeah.
Sir,
So I think it was wonderful. It is in just 1.5 hours, so superb. We could finish all 4 with reasonable amount of good discussion. Fine. So I think we can conclude.